panel today and to be part of the program. Just a little housekeeping to begin is my disclosures, which you see listed here. I don't think any of them will have any impact on the discussion today. So I've been tasked with talking about training and credentialing for notes. And as a general surgeon who does a lot of flexible endoscopy, I find this area interesting, the amount of energy that goes into the discussion around this, when to me it seems that we haven't quite defined that killer application yet and how we're going to do it. But I wanted to spend my 15 minutes talking about the arguments that are made on both sides of this coin and kind of walking through those arguments. So it kind of comes down to this type of struggle. Who should be doing this? Who has the skill set to do it? And you hear arguments on both sides of this coin. Surgeons should be doing it. This is surgery. This is what we do. Gastroenterologists should be doing this. Those surgical people don't know what they're doing with the flexible endoscope. And so let's go through this argument a little bit, some of the arguments you hear. One argument I hear is around training. Okay? So surgeons, we train to do surgery. We spend a lot of time in our career to learn procedures. We spend a lot of time in a hospital to do this. We spend years developing the art of surgery. Let's look at the numbers really around training. So surgeons, if you do a standard general surgery residency, go on to do an MIS fellowship, depending on whether you spent any time in a lab along the way, you may spend 6 to 9 years in your training after medical school learning your craft. Gastroenterologists, 6 to 7 years. You got the 3 years of medical residency, go on to do a GI fellowship, and then many are doing advanced GI fellowships as well. So the training time is comparable. Procedures, depending on where you train and how aggressive you are, you'll probably finish your training in surgery when you add on that fellowship experience to maybe as many as 1,200 procedures. That number's changing with our current rules. Gastroenterologists, probably at least 1,200 procedures, could be double that, depending on where they're training in the experience. Surgeons are the masters of the rigid scope. We learn laparoscopy, we can move that thing around the abdomen, we understand how to manipulate that endoscope. Gastroenterologists, masters of the flexible scope. And despite the fact that we're in a society that happens to include a lot of surgeons who do flexible endoscopy and do that well, as a total group of surgeons across our country, in general, we have to admit that most of us have fairly rudimentary skills with the flexible scope. Surgeons, masters of extraluminal anatomy. We're used to looking at that extraluminal anatomy and navigating around the abdominal space. Gastroenterologists are masters of intraluminal anatomy and pathology. And depending on how notes evolves will depend on which skill set will come to bear in this area. Surgeons understand surgical principles, and this may be a differentiating factor. So surgical principles are the ability to retract, dissect, divide tissue, excise tissue, and then re-anastomose. Those are surgical principles, and those may be a differentiating factor in the skill set of this group. Now, having said that, it doesn't mean that non-surgeons can't learn to do surgical type procedures. So this is a partial list, really, of a number of disease processes that used to have surgical solutions exclusively and now have at least flexible endoscopy solutions as either an option or as a preferred method of managing this. Everything from, problems in biliary tract disease. When's the last time one of us has had to do a common bile duct exploration for a retained stone in a normal caliber duct? We have endoscopists that can do that very well now. Even things like Barrett's esophagus, the whole paradigm is changing for things like high-grade dysplasia and intramucosal carcinoma. Other arguments. Gastroenterologists will never take on the risk of notes. The riskiest thing they do in their day is ERCP and PEG. The least risky thing we do in our day is ERCP and PEG as surgeons. Well, I wouldn't put all your eggs in that basket. In fact, let's look at the people who really pioneered a lot of the work in notes, particularly in the laboratory. This is the Apollo group. Outside of Sergei Kantsevoy, who has surgical background, these are gastroenterologists, skilled endoscopists who are taking the paradigm to the next level. So there is a group, at least a subgroup of expert gastroenterologists and endoscopists who are willing to push into this field. So we need to stop this argument of us versus them. I don't personally think it's productive. I think it's premature because we haven't defined exactly what we're going to be doing and what the technology is going to look like. And I think it's much more productive, as you've heard through the morning, that we need to work together to help develop this area and to do it with patient safety and patient benefit in mind. We don't want this to happen, okay? The laparoscopic era was ushered in by some missteps. And certainly in the early areas of gallbladder surgery, or the early days of gallbladder surgery, there were missteps. This is actually a support group of people who have had common bile duct injuries from laparoscopic cholecystectomy. And we don't want to repeat this problem when we introduce notes. And so that was the whole impetus, or at least a major part of the impetus behind NoSCAR, which you've heard very well described early today. And this is an important, really groundbreaking initiative to help to safely introduce new technology and new techniques for the care of our patients. What we really need to do is we need to create environments where healthcare providers, whatever the specialty, can learn new technology and adopt new techniques and introduce that to the care of their patients safely. And in fact, the American College of Surgeons is quite ahead in this area. They have begun the accreditation of education institutes across this country. And there are a number of these, and their goal really is to create a network of accredited institutes that can assist surgeons, residents, medical students, and other members of the surgical team in achieving the knowledge and skills in order to provide optimal care for surgical patients. If you generalize this a little bit and took out those words surgery and just kept it as procedures, these types of institutes could work for introducing any type of procedural technology, really to any specialty. And that's kind of a scrolling partial list of the already accredited institutes from the American College of Surgeons. And their vision is that they want islands of connectivity across the country, places where a healthcare provider can periodically go throughout our career, have a relationship with this institute, and learn from that institute on how to adopt new technology into our practice, and then to support those practitioners when they go back to their home environment and begin doing procedures with that. These institutes are created to deal with these kinds of problems. These are arguments we hear in surgery. Young surgeons don't know how to do open surgery anymore. They've lost the skill. They can't rescue themselves when they get into trouble from laparoscopy. Flip side, senior surgeons are reluctant to adopt new technology. And so maybe these institutes can help address that issue. The gastroenterologists are going through the same types of arguments within their area. So this is a thing that we hear through places like the training committee at ASGE. We have too many colonoscopists, if you will, endoscopists that perform screening colonoscopy all day, and they have forgotten their therapeutic armamentarium. We need a place for them to go to relearn these tools and to maintain their skills when we have paradigm shifts like screening colonoscopy or a blood test to decide what your risk for malignancy is. So these institutes can be all types. This is our inanimate skills lab at the Methodist Hospital, where I'm located in Houston. This is actually now an incorporated part of the training program. So we have practitioners from everything from surgery to neurosurgery to family medicine, obstetrics and gynecology. We have our PAs coming to this lab, and they have required skill sets that they have to learn and demonstrate in a completely inanimate environment. And you can do some pretty powerful things with some rather simple tools. This can get much more complex. So we have completed phase 1 of an education institute, which we call MIGHTY. And phase 2 is under development to develop really what we think is going to be a model for an extremely comprehensive education and research institute, a home base where physicians who are procedurally based in their practice can come and learn new technology and new techniques. We'll be housed in this building, which is underway. We will encompass about 40,000 square feet of this building. And it's a place that's serious about its activities and comprehensive in its scope. So part of this type of place has to have a procedural skills lab, a place where you can come and learn this technology and rehearse it in a safe environment with the appropriate proctoring and training. And this is how that skills lab will look in the mighty project. We need a simulation environment, which we call a virtual hospital, where we can recreate any part of the healthcare environment from the hospital, so that not only the physician who's performing the procedure has rehearsed that procedure, but the entire team has done that as well. Simple things. We've seen long instrumentation today, over tubes, guide wires, long instruments. How do you manage those in the operating room and keep them sterile? That's not what we typically do in our day-to-day environment. How does our scrub nurse know how to prepare that? And how do we deliver that safely to the patient? And rescue ourselves if there's a trouble. This is what you rehearse in the virtual hospital environment. You need a place which we call the med presence room, where practitioners can come and watch experts perform their art. And it needs to be done in a way that does not disrupt the normal care of patients and does not compromise that care by risking things such as contamination. So this is a med presence room where people can come and learn about what surgery or what procedure is going on in the operating room. You have the feeling you're looking through a glass window. The building that you see on the board there, the operating room, is 3 buildings away, and this communication is done all over a network-based system. And it's a personalized experience. So not only is the person who's sitting in the chair looking at what's on the screen, but they can modify that experience from their own computer monitor at their station. And it needs to be a robust communication like this, which is the operating room side of that interaction. Simulation is an important component of this as well, and simulation is still in its infancy for whole procedure training. We have a number of models for both flexible endoscopy and laparoscopy to help provide simulation, but the real work of simulation is validation of the modules that we can provide. SAGES is moving forward in this area. They are a leader in the laparoscopic world for doing this with their Fundamentals of Laparoscopic Surgery project, and now they are developing a project called the Fundamentals of Endoscopic Surgery. So this is a validated training and testing program that you can put somebody through this program, test them on their endoscopic skills, and have a real objective, validated measurement of how well they can perform flexible endoscopy. SAGES is collaborating with industry partners to develop a hands-on module as well as a didactic portion for this, much like the FLS module. And an interesting part of the development of this module is actually the clinical side. So Jerry Freed, who's one of the leaders in understanding the metrics of education and skills acquisition, says you can't simulate what you can't measure. A common problem with the development of simulation is that the simulators are designed from companies who are very smart at making things look pretty good, and they get input from experts on how it should feel and how it should look. But what you really need to do is you need to start at the back end of that equation first. You need to say, clinically, what is important for accomplishing this task? What are the skills that someone needs to do this well? You need to validate that understanding by testing that, and then you go and design a simulator that will help you gain those skills. So along with the FES project is this. This is called GAGES, the Global Assessment of Gastrointestinal Endoscopic Skills. This is a one-page scoring sheet where I can walk into the endoscopy suite, watch a practitioner perform an endoscopy, and give them a score on how well they did for that procedure. And it's broken up into fields that speak to different skill sets that are required to do this, so that if you score low in one area of this document, we hope to then develop models where we can take you back to the simulation lab and improve your skills in that area. At Methodist, we're taking concepts of metrics and the acquisition of skills to other levels as well. And so this is an example of a thermal imaging platform that is used to measure procedural competence, at least as a surrogate for procedural competence. So this person who is performing laparoscopic suturing and knot tying is being monitored by this camera, which is a visual and thermal imaging monitor that comes up with these types of images. And the computer measures things like heat distribution in the frontal area, perspiration over the lip, the distance between the brows and the intercanthal folds. And it can discern the difference between someone who is not at stress, like this person, and someone who is at stress like this person. And we hope to use this as a surrogate for procedural competence, which doesn't rely on what procedure you're doing. It relies on your physiologic stress to what's happening as you're going through that. The last thing I'll say about the training and credentialing process is that people are going to get the skill sets they think they need to do this, almost regardless of what we say about what they have to start with. So if you talk to Drs. Pleskow and Shadani in Boston, this is a group of advanced therapeutic gastroenterologists who have a very good program, a fellowship program for advanced endoscopy, where gastroenterology fellows traditionally go to learn advanced techniques beyond their usual GI fellowship. And over the last 2 years, 2 of the people that have gone through that fellowship are surgeons. So surgeons doing an advanced GI therapeutic flexible endoscopy fellowship. Likewise, Ponsky and Marks at Case Western are bringing gastroenterologists into their group to learn surgical principles through the lab so that these people are getting the skill sets that they need. So I think in the end, this is what I would want to leave you with. Let's do what's best for the patient, let's keep our egos in check, and the rest will follow. Thanks for your attention.
Thanks a lot, Brian, and thanks a lot for particularly destroying my last debate there. The next session is